Hello, everyone. Welcome to session 6 of the Climate Catch Lab seminar series, and we're absolutely delighted to have Trish here today. I'm not going to do the long name. It's a casual fireside chat today. My name is Rebecca Patrick, and I'm the academic convener of the Climate Catch Lab. CATCH stands for Collaborative Action for Transformative Change in Health and Healthcare. And this is an initiative of Melbourne Climate Futures, Melbourne School of Population and Global Health, as well as Melbourne Medical School. And so part of our remit is to make visible the issues at the nexus of climate and health, and engage people in the conversation around climate and health issues. Before we sit by the fire and have a conversation with Trish, I'd like to start with acknowledgement of country and our First Nation people and the traditional owners of the lands of which we're meeting. Whether you're on Zoom today, hello, and thank you for joining us, as well as the people here today, and acknowledging the caring of country for more than 60,000 years of our First Nations people across we now call Australia and our home. So the agenda or session format is I'll start with some questions by the fireside here with Trish, and then importantly open up to the group that is joining us both on campus today as well as online, so that you have an opportunity to ask Trish about her incredible experience and knowledge at the nexus of climate change, migration and health. Before we start with the questions, let me just remind you of the incredible journey that Trish has made to this point, and why we've invited Trish to have this conversation today. So Trish is currently a postdoctoral researcher at Heidelberg Institute of Global Health in Germany, as well as being an adjunct academic at Monash University in the Faculty of Medicine, Nursing and Health Sciences, as well as, and we're very fortunate that she is a fellow of the School of Population and Global Health, and a really valued colleague of ours in the climate and health field, and particularly Catherine Bowen, who's the director of the Climate Catch Lab. There's been some great work over time together. When Trish hasn't been doing all that, prior to that, she was a clinical nurse specialist, so a clinician by training, having worked in Medicine Sans Frontiers for several years in both clinical and governance roles. Worked in South Sudan, the Pacific and Europe, and had collaborative research partnerships with Burkina Faso, Bangladesh, Chad and the Maldives. Oh, the Maldives, fantastic. We will be asking you questions about the Maldives. Your current research focus, though, is on climate change-related migration and health and humanitarian assistance, as well as climate resilient and low carbon health systems. So we're absolutely delighted to have you here today, Trish.
Rebecca.
You've just travelled from Germany and you've been back home for a few days. Mm-hmm. Yeah, absolutely. Spending time with some family and...
Yes, yeah. Came back for a wedding and then also for this. So
absolutely.
Yeah, it's nice to be home.
Yeah. And what do you love most about coming back to Australia? What's nice? What do you enjoy?
Our family mainly, but also the beach. I miss the beach a lot. Grew up on the beach, and although I live near a forest in Germany, I'm a beach person. So
excellent.
The water, yeah.
We've turned on some reasonably good weather in the last.
Yeah, well, yeah. There was a window for the wedding. That was the main thing. The rest was very windy, but it's not bad.
Weather and climate change go hand in hand, so that's our lift-off point to dive straight into some of the questions I had prepared for you. So who are you, Trish? And what do you care about? And how did you first get involved in this area of climate change, migration research?
Yeah, good question. So, yeah, my bio was kind of all there, but in a nutshell, I had a I just finished my PhDs, but I'm a bit of a vintage version of a postdoc because I had a career before that in as a clinical nurse specialist, as Rebecca said. So I worked in healthcare systems in different countries, in Australia and Indigenous communities, in Europe, different countries in Europe and in South Sudan with Doctors Without Borders. And what brought me to climate was, well, I was equipment nurse actually in Alfred Health, and we just found, the clinicians there found that there was a real lack of concern around the environmental impact of healthcare. So we started advocating for more green initiatives. So it was a real like grassroots project, but we also did sort of catalyse some top-down action as well when it came to the consultation at Alfred Health about what the values are and what our strategic plan should be. It was very loud at that point, and that was about 15 years ago now, that the staff wanted to practice more sustainably. So that kind of got me into, you know, environmental sustainability in healthcare. And then I was matched with Catherine Bowen in a mentorship program and started my PhD, which focused on the nexus between climate change, migration and health. Yeah, so that kind of brought me here.
So it started with your lived experience, a level of maybe frustration, passion to see some changes. And so primarily voluntarily in that context, you started to shift the environment around you.
Yeah, and I think that's a common story amongst people that are in this field, becoming more aware of their environmental impact of their activities, both at work and at home. Also, I find a lot of mothers or parents generally start to think about that, and that brings them into that, you know, into that space where you kind of do what you can where you are with what you have, and then you might be able to move on from there.
Okay. Thank you. Let's dive straight into what we're really here to talk about, and that's the issue of climate migration. And what are you seeing as the biggest trends with regard to climate migration? I know you've worked in a global sphere and regional context. What are the things on the trends and the horizon?
Yeah, the big trends. Well, it's probably good to say first that people have always moved due to environmental and climate change. So it's not something new. And climate change acts on the existing drivers of migration, so environmental, economic, social, political drivers of migration, and climate change kind of acts like a force amplifier, a little bit like it does in health. You know, it doesn't necessarily create new problems, but it shapes health issues and it shapes patterns of migration. So you can't, it's very, when you look at this literature at the nexus between climate change, migration and health, you kind of see two fields. The climate change migration field of research, which is around 30 years plus old, and then you have the climate change and health. And then what I looked at with my PhD is where these overlap. So what studies look at climate change, migration and health. And often within that, you still see kind of climate change migration research that has some health findings and climate change and health research that has some migration findings. So I think in science, like we do tend to focus, we have to, because we have to become specialised in a certain area. Sometimes we can kind of lose the big picture. So there's kind of this emerging field of climate change, migration and health research that tries to, you know, zoom out a little bit. In terms of the big trends, I suppose the go-to report would be the IPCC AR6, and you see more findings around climate change, health and migration in that now. Well, in previous years as well, obviously there's a long history of that, but in the AR6, the big trends they're talking about is seeing climate change. We're seeing that it's increasingly a driver of migration. And that works through like the sudden impacts of climate change, where you see more extreme weather causing forced displacement. So that's kind of the more obvious direct route. But then there's this indirect route too, that's more subtle and difficult to detect, which is the slow onset impacts of climate change. So you get drought, sea level rise, and the types of climate impacts like extreme heat over time that undermine climate sensitive livelihoods. So it might be a case where if not for climate change, then that particular type of mobility pattern might not have been the case, but it might be difficult to prove that. And the people who are moving in that context might not even be aware of it. So, yeah, they're the big trends. I suppose you could talk about climate like hotspots in terms of where migration is happening in the context of climate change. And they would be the places that are highly vulnerable with low adaptive capacity, people whose livelihoods are very dependent on agriculture, climate sensitive livelihoods. And generally in the research that I've done in Bangladesh, in Burkina Faso, in Chad and in South Africa, people that have a lack of other options, really. So we see people trying to adapt in situ, and when all of their options are exhausted, then sometimes the only thing left is to move. Yep. People would, in many cases, in my research anyway, people would prefer to stay, but in the absence of opportunities, they are sometimes forced to move. And I remember a qualitative research project I did in Barasso in Burkina Faso, where a man actually said, it's my obligation to move. I have no choice. He really didn't want to leave his family and children behind, but there was no harvest in successive harvests, and he had to go, even though it wasn't a successful migration. Like, it didn't end up benefiting him or his family.
I'd like to come back to the case studies and your types of methods, but just when you say health, what do you mean by that? So what are some of the health issues? What, is it that broad definition of health? Could you just sort of unpack that for our colleagues here?
Yeah, that's a question that is often asked in this kind of nexus research. What are the impacts, the health impacts of climate migration specifically? There's a lot of assumptions underlying that, and then it comes back to the ongoing debate of, is this climate migration, is that person a climate migrant, climate refugee? And then there's quite a lot of controversy still there. I find in the media, they're very comfortable to use that terminology, but in academia, it's more of a taboo. And there's good reasons for that, including it's difficult to attribute a certain migration to climate change. And I've lost my train of thought. What was the question again? Health impacts.
Yeah.
So that's kind of connected to the idea, what are the health impacts of climate migration? They're very similar to the health impacts of migration. We've got this human desire to kind of put all these migrants in boxes, but at the end of the day, migration is multi-causal. And it's a confluence of factors, political factors, economic factors. People might say that they're moving because they don't have a livelihood there, but it might be climate change undermining that, or the lack of government capacity to support them during those tough times of the harvest. If that was there, then they wouldn't have to move. So there's a lot of complex factors interacting there. So yeah, in my research, I found that the studies that did look at climate change, migration and health did find a lot of the health issues that migrants experience as well, including food and water security issues, infectious diseases, particularly, with forced displacement, when people are confined to high density kind of temporary accommodation. You get sexual and gender-based violence there as well. And people, non-communicable diseases are a huge issue as well. And so there's no continuity of care. So people deteriorate. They have more acute attacks on their chronic conditions. Kids miss out on vaccinations. But I don't want to make it sound all bad, because in one of my studies in Bangladesh, it's actually the paper that I wrote was called The Risk Exchange, that I wrote with Catherine for my PhD as well. Because there was an exchange of health risks at the origin and at the destination. So we were talking to people about what it was like in Bola when they lived rurally before the river erosion kind of compelled them to move to Dhaka, which is an urban slum. And they would say things like, the water was actually better back home. We had our own well. And here we're crowded with all these people. Then the mental health impacts as well. People would say it was more peaceful in Bola. And here, this old lady was saying she has no peace. She can't even go to the toilet without a line of 50 people. Those kind of things just kind of stick in my mind. But then some other people talked about benefits of moving as well. Like they had employment, they had, they had income earning capacity, and that meant that their opportunities to purchase food, diverse food, were increased. Other people talked about moving in communities. So there's a bowler slum part of Dhaka where lots of people from bowler are. So they kind of maintained their social networks and had like social capacity, social capital at the destination, and that protected their mental health. So I think maybe a more interesting question to ask about climate migration is how can we minimise the negative health impacts and maximise the beneficial health opportunities of the destination.
We're going to come back to that and actually ask you to explore that in a moment, because that's a fantastic question. And I suppose that goes to the idea that often when we think about climate change, we think of the impacts, the detrimental impacts, but migrating groups also bring strengths and capacity and an incredible range of capabilities to the new settings in which they're moving to. Any thoughts on that? Perhaps from the stories as well that you've...
Yeah, I think from a research capacity point of view as well, we have to take a bit more of a strength-based approach. And my background's in health promotion, so I'm more used to doing that. But then when you get into the biomedical kind of model and curative model, it tends to be much more disease-focused. So I do see kind of almost like a bias in the studies towards looking at diseases. And there's also maybe we're a bit compelled to always link climate change to negative health outcomes. And, I've reviewed some papers where they're trying to draw links between climate change and a whole range of negative health impacts, sometimes without like an empirical basis. So it might be good to think more about how can we, improve health. What are the opportunities there? Because people move from areas of climate-related health risks, and sometimes they move into areas of climate and health-related risks or different ones, but maybe those reduce that. Migration is also probably a good time to bring up the fact that migration is not always a problem to be solved, because sometimes, that's kind of the underlying assumption to the conversation, because migration also has the capacity to be adaptive to climate change. It can reduce risks. I mean, that's why people move. Yeah.
Mm-hmm. So can I just stay with your methodologies though? You've mentioned strength-based, the limitations of some of the approaches, and that some of the literature is quite similar with regard to looking at sort of deficits or impacts. Tell us about the way that you research and some of the values that drive your research.
Good question. I'm a big fan of synthesis research, actually, even though the Europeans kind of turn their noses up at it and impact and applied research. But synthesis research like scoping reviews, systematic literature reviews, I just find it really valuable, especially in this information age where you can kind of get trapped in a bubble. And, that people often have an argument and then they search for evidence for that argument, and then their opposition will do the same thing. And they'll find primary studies and they'll use that as evidence, and you just kind of don't get anywhere. But if you use a synthesis research approach, you can bring the level of research, like if you think of I don't know if you've heard of the hierarchy of evidence, but you can bring the evidence up to a higher level. So instead of saying, well, look, this primary study says that migration is really bad for health and it's maladaptive. And then your opposition kind of says, well, look at this study. This says that it's beneficial for migration. But then if you say, okay, let's look at all the studies over 20 or 30 years and see like not just the consensus, but the nuance, and also do a quality appraisal as well, because often people are referring to evidence where they've got an extremely small sample group or a certain particular set of circumstances that aren't replicated in different settings. So that's a long way around saying I like synthesis research, although it's painful to do and it takes a long time.
It's kind of two bodies of evidence, climate and health, climate and migration, and part of your synthesis is pulling those two together.
Yeah, exactly.
Insights that's there.
Yeah, exactly, to get a bigger picture. And I think I got lucky because a lot of the UN organisations and the NGOs are interested in doing that as well, because there's kind of this strategic emphasis to mainstream climate change through your work. So the WHO, migration and health need, according to their strategic plan, so they need to mainstream climate change into their work. And then MSF, Emergency Humanitarian Organisation, also through their strategic planning, want to mainstream climate change through their work. So they're trying to make sense of all this evidence, because there's been such a huge explosion of evidence as well, that I find these practical, like policy and practitioners are kind of saying, give us the lowdown, like put this together and tell us what it means. Yeah, so synthesis research, but I'm also a qualitative researcher.
I wanted to ask you about that.
Yeah.
About the qualitative and the working with people with lived experience, I'd anticipate. Yeah.
And that, I mean, nursing and midwifery is very strong with qualitative research. They kind of really led that in health from early days. I mean, I think it's just the quotes that kind of stick in my mind, and talking to people about why they're moving, because it's complex. Yeah, like if you did a quant or you did a modelling study, you might come out with the numbers of people that are moving. And I've kind of done both. Like I'm doing some mathematical kind of modelling on climate at the moment, and I'm just keep on asking myself, yeah, but you don't know why they're moving, do you? You know, the numbers. But you know, there are limitations and strengths of both approaches. That's why mixed methods is also a really good one to look at for this particular complex situation. So you can get the numbers, but then you can also get the words to explain the why and the how, as opposed to just the what and how much.
Trish, is there a particular story that sort of has sat with you, not necessarily of negative impact, but of empowerment, or something that has resonated for you, like your mind goes to? And are you willing to share it?
Yeah, sure. I'm just trying to think of, I've got so many that I'm just trying to think of one, like related to climate change, migration, health. Yeah.
In your research? Or
just like probably best to go with what's most recent. Like I'm working more, one of the conclusions of my PhD was that we need to make health systems more climate resilient, environmentally sustainable and migrant inclusive. And then that was kind of my conclusion. And in a lot of fora, people were kind of saying, well, what do you mean by that? And how do we do that? And I was like, oh yeah, I probably should look into that next. So because I like applied implementation research, we're now doing vulnerability, capacity and adaptation assessments of health facilities. So that can be done, as many people know, at the national level in order to develop a national adaptation plan. It can be done at the systems level as well. But there's a lot of clinics that are just like me as a nurse at Alfred Health going, what can we do now with what we've got, where we are? So, I mean, the story I'm getting to is that like a couple of months ago, we were doing assessments in the Cedarburg region in South Africa. And we were like actually visiting clinics and interviewing nurses who were running these clinics alone, really, really under extreme circumstances. And the last clinic, we tried to get to it, but the whole road had been totally washed away by a flood and they'd been cut off. So that was the first kind of climate impact that we encountered. They didn't have the communications were down, they didn't have their supplies. Anyway, we found another route to go there. And then we found this nurse who was just the only clinical person in that facility. And she was on like the edge of a township with thousands and thousands of people. And it was raining and it was payday. So everybody was like lining up to get their weekly pay, and the shops were full because people got their food straight after their pay. A dog had been run over. It was lying on the side of the road. There was just mud everywhere. I just remember the feeling of that, and the kids like just sopping wet in very light clothing. And, the question is here, how do you make this facility more climate resilient and environmentally sustainable? And actually, the nurse there hardly had time to speak to us, even though we'd send her a lot of emails, but she's not checking her email because she's just got so many patients. But luckily it was the end of the day. And really, what would build climate resilience most there, according to this nurse, would be more staff. because she's just beside herself with this nurse-patient ratio that's extreme. So I think it just kind of reminded me that every clinic is different within a health system, like every facility is different within a health system. And sometimes if we talk about like a climate smart health workforce in Australia, we're talking about teaching health professionals about climate change and health, but there they don't even have trained and a safe number of trained people, and that might be what makes them most resilient.
The starting points are different. Yeah, yeah.
Mm.
I've got one more question before I will open up the floor, which connects to policy. So if one size doesn't fit all, what are some of the policy directions? Is there some interesting policy development happening in the space, or not so interesting that we should be concerned about?
Yeah, that's a good question. I did do a policy synthesis after my systematic literature review just to say, what are the principles coming out of this research, just for policymakers to, have a principled approach, that's helpful, I find, because it's so context specific. But generally what the literature on the nexus between climate change and migration and health is saying is that we shouldn't encourage migration as a global solution or as a universal solution, because it's very context specific. So, and sometimes migration can be maladaptive, like it might not be what's needed. So it shouldn't be the go-to solution necessarily. It's better to invest in climate change adaptation and disaster risk reduction, and remove barriers for people to move, because when they need to move, there shouldn't be barriers there, and this is all coming from a health perspective. I'm saying these are the policy principles if you want to reduce or avoid the negative health impacts of climate-related migration. And the other couple of principles were that people should be involved in decision-making about resettlement and relocation. And we should be thinking about not just the migrating community, but also the sending and the host community, because they're also affected by the movement.
I just have one more question to build on that. We know from popular media around climate migration in the Pacific, for example, and I think it's New Zealand, for instance, has got some supportive policy to support migration. Any thoughts on that? And I know you've worked in the Pacific as well, which brings us closer to home as well.
Yeah. There's lots of talk about having like a climate migrant status, like adding it
as a visa category.
Yes, as a visa category. So the New Zealanders were ahead on that, which a lot of people applauded. But it was a bit controversial because I did read some articles, or I can't remember exactly where it came from, where the sending community was saying, well, if you're adding kind of like an incentive to leave, and then there's a negative kind of impact on the people left behind. So they were saying, no, don't create a climate migrant visa. We would prefer that you help us to adapt in place so we don't have to move. So I think that was really interesting situation. Yeah.
So that goes to starting with deep consultation and understanding the needs of communities rather than making assumptions and policy responses that haven't necessarily been identified by those affected. Okay, yeah, sure. Okay. I have so many more questions, but I won't do it. So we'll take one question per person and then come back to second questions. We've got online questions and we've got our first colleague in the room. And would you just tell us your name, and we'll just give you a microphone, and if you could offer up your first question.
Yeah, I'm Hans Baer, an ecological and health anthropologist. I've written several books relating to climate change. The first one was titled Global Warming and the Political Ecology of Health. The most recent one is Building a Critical Anthropology of Climate Change, but that's enough for me. Two-pronged question. First, it seems to me that a lot of the discourse has shifted from mitigation to adaptation and resilience. But we can only adapt so much. So I'm fearful that this shift is a kind of conservative shift. The other one is there are many drivers of climate change, but one of the drivers are airplane flights. And a lot of climate researchers are doing a shitload of flying around the world. And one of the books that I did is titled Airplanes, the Environment, and the Human Condition, that was published just before the COVID pandemic. And at that time, 5 to 6% of emissions came from airplanes. And now that we're not really in post-pandemic stage, but kind of, the flying is continuing. And in fact, in the chapter, there's a chapter in our book dealing with how researchers, scholars who are looking at climate change need to address the considerable amount of flying goes on. So that may be an embarrassing point, but I'm going to raise it. The elephant in the sky.
Thank you. And it sounds like you've been extremely well engaged in this area, and thank you for offering up those questions. Start with you, Trish, on some parts you want to pick up there.
Yeah, the first question is a really good one about are we moving? Is the discourse moving? I find it is. I was at the last 3 COPs, and the people that have had much more experience than me at COPs were kind of confirming the same thing, that we really started talking a lot more about mitigation, and then it's moving more to adaptation. In the last COP, it even went further to loss and damage. And the 4th pillar is geoengineering. So it's kind of like, I like the analogy to public health with that as well, like mitigation's like prevention. We don't invest enough in prevention. And then we've got adaptation, which is kind of a little bit like the next stage of healthcare, secondary prevention and curative medicine, which is really expensive. So the further you go along, the more harm it does and the more it costs and the fewer the benefits. And I think there's a kind of an interesting analogy with moving from mitigation to adaptation to loss and damage to geoengineering as well. And I think we kind of have to challenge our dichotomous thinking there a little bit, that it's not sequential, and think carefully about the degree to which we invest in each of these solutions. I mean, the prevention paradox comes into it a lot too, doesn't it? Like, it's hard to demonstrate that you prevented something, which is the problem we have in public health and preventative medicine as well. We get so little funding because, we can't say, we saved these many. It's more difficult to demonstrate that we prevented ill health than with curative medicine. The second one, I think that's a good point. That comes up every COP as well. But the interesting thing is that comes up in the health community a lot, amongst the health community. So there's kind of tendency to hold ourselves to higher ethical standards than everybody else. I tell you what, the fossil fuel industry isn't talking about that when they arrive at COP in their private jets. So, I mean, I think we have to look at the big picture. It's a little bit of like the dilemma between different types of ethics, like, is this essentially a wrong thing to do, or are you consequentialist and you're thinking about the outcome? I'm more a consequentialist person. I'm thinking about the outcome. And if my work is all about mitigating climate change and reducing the negative health impacts, then obviously we rationalise our travel, but I think the investment is worth the outcome.
Thank you. Come back to that. Is there someone online? Thank you for starting us off. Yeah.
Hi.
Hi.
Hi, I'm Smriti. Can you hear me properly?
Yes.
Okay.
We can hear you. Thank you.
Hi, Dr. Trish. It was fascinating to hear you. I'm actually on a research fellowship at Japan, working on the topic of health emergencies and climate change. In fact, I've been in talks with Professor Bowen to come to University of Melbourne next year to also further the project. So my question to Dr. Trish would be, so since I'm also trying to kind of keep track of what is happening at COP and how the conversation is going at COP 29, coming from India, I also want to understand what the context of. I feel like the global narrative when we are talking about climate change and health is focusing more on how the how the health sector is a polluter, and they're highlighting that it's the fifth largest polluter. But I mean, COP is also kind of talking about, these four other polluters that are above health. So my question is that why not question climate action financing that can also be then, invested in health instead of just focusing on the fact that health sector is a polluter, which then has, impacts like migration, etc. Would, in your opinion, would that also be because the global north is more sort of, focusing on the adaptation actions because migration and it would be more of a problem for the global south, which is more vulnerable, if that sort of makes sense. Thank you.
Yeah, so thank you for your question. If I understand correctly, you're asking, you're saying that the discourse is really concentrated on mitigating the footprint of healthcare?
Yes.
Yeah.
Sort of like a bit lopsided.
Yeah, I mean, it's kind of a bit disorientating, isn't it? Sometimes it's hard to lose the bigger picture. It's hard to see the bigger picture. But I do find that there's a lot more on adaptation now than there used to be, and also on loss and damage. So at Heidelberg Institute of Global Health, there's quite a bit of work on quantifying the health impacts of climate change for loss and damage discussions. There's a lot on climate finance as well. So and on climate resilient development, so which is kind of superseding mitigation and adaptation. So I see it becoming more, although I agree with you that it was a lot about mitigation, it was very problem focused. I think it's getting more towards solutions focused. The other thing that you said that reminded me of something is that I do think the work around climate resilient and low carbon health systems kind of focuses on high income countries and decarbonisation. I noticed that quite a bit at COP. A lot of people did healthcare without harm, and the Global Climate Health Alliance did as well. And maybe that's like a product of the NHS being really ahead on that point. But there is like a lot of interesting work happening on building climate resilience sustainably in developing countries. So I think that will be one to look out for at COP29, because there's definitely more interest in that growing at the moment in research and in this.
I have another question to follow up on that, but is it? Yes, please.
Yeah, hi. Thank you.
We'll just give you the mic so our colleagues online can hear you.
Hi, my name is Pari, and I have a background in applied statistics and some exposure to global policy and climate change. And I've also been volunteering for a project in South Sudan. So my question is a very quick one. It's around attribution science. So how do you relate a health impact specifically to climate change? So could you give us a little, throw some light on that?
Yeah, that's a big question. I probably wanted to, Catherine. Yeah, Catherine would help with that. Like one of the other things that I was going to talk about was the challenges in this research, and that's definitely one of them, attribution science. So there's a really good paper that I would recommend by Chris Ebi and Andy Haynes called Attribution, Detection and Attribution. And it's about attributing health impacts to climate change. And yeah, I am more of a synthesis researcher and a qualitative researcher. So it's probably not my strength, but that's an excellent paper on it. And that's something I noticed in my systematic literature review as well, that we're getting a little bit lazy with that. Like the papers that I saw kind of didn't have that detection and attribution part of it. It just kind of replaced the word natural disaster with climate change. And when I looked at the data sets, like we're working with a dynamic cohort in a health and demographic surveillance system that's doing that work. So I know people that work specifically on that. And so we've got data on population movements, on climate change, and then on health, overlaying all of those. And but Yeah, that's like the sweet spot when you have all of those data and you can integrate it. But I found in my systematic literature review, there were 3 ways people were doing that with those different data sets. They were doing it just in the background, like talking about climate change in the background of the paper, but doing no detection or attribution in the guts of the paper. And arguably not all the papers have to keep proving this as well. We are interested in the climate signal within certain health outcomes, but I started to think also about the analogy with smoking and cancer. We don't always have to prove, do we, that that smoking caused that cancer. At some stage, we're kind of going to have to recognise that climate change is real. It's causing people to move. And there are some scientists where it's important that they work on detection and attribution, but not everybody. Other people have to work on solutions as well and just accept that climate change is causing migration, just like smoking is causing cancer, and moving on. So that was a roundabout question, but that's an excellent paper on that. I'll show you, I'll tell you, I can send it to you later.
And on Chris Ebi, we're absolutely excited that Chris Ebi, who has a lot of knowledge in terms of attribution, vulnerability, capability, and adaptation assessments, joining us for 2 weeks in October this year. And there'll be various opportunities to connect with Chris and her work around this area. So keep an eye out for that. It's coming your way. I think there was a question. Oh, is there one online, or should we take? Yeah. Hi, Sam. Good to see you.
Hi, Trish. I'm Sam. I'm studying masters at the moment, looking at environment and public health. And I'm doing a subject at the moment looking at disasters and humanitarian aid. And I'm quite interested in how armed conflict, or the relationship between armed conflict and climate change and climate impacts. So I'm wondering, given your experience in MSF, if you could talk a bit about how you manage migration within countries where people are faced with conflict and climate impacts?
Yeah, that's a good question. Yeah, it makes me think about how a lot of this research looks at, how there's direct and indirect impacts of climate change on health. And that used to be referred to as primary, secondary, and tertiary. And the primary ones are like the extreme weather events, deaths and drownings, etc. And then the secondary ones are the way that climate change works through ecology, through infectious diseases, food and water to cause disease. And then there's the tertiary ones, which is migration and conflict. And they're probably least studied because they're removed in space and time, and they're difficult to attribute and prove causation. And so the work on climate change and conflict is kind of similar to the work on climate change and migration in that way. Like it is difficult to demonstrate that connection. But your question was more about how MSF works in this context. MSF has been engaged in climate issues much more than in the past 5 to 10 years, and now it's part of the strategic plan. They recognise, and there's a lot of papers on the nexus between climate change and humanitarian assistance. They recognise that it's going to increase the humanitarian needs. And there's one really good report by the ICRC called The Cost of Doing Nothing. And they say humanitarian needs could double by 2050 without appropriate mitigation and adaptation. And currently, humanitarian needs are met by less than half. So that's an extremely concerning situation. And so, yeah, the way MSF is thinking about it now is it's by nature a very reactive organisation. So in a way, it's fit for purpose because it responds to need. But we do have to think about like the scale of the threat now, and that's why MSF is now present at COP and more engaged with the ICRC Climate Centre on trying to better understand how climate change is going to impact not just the needs, but also their operations, because it makes their operations more difficult. And at the same time, they're trying to reduce their carbon footprint by half by 2030 as well. It's a commitment that they've made.
Hi, Janie.
Hi, I've got lots of questions I could ask, being an alpha clinician and into sustainable healthcare, but I was actually going to go back to migration and that attribution factor. And we sort of talked about how it was sort of difficult, or there is research out there about attribution of climate change to health, but we hear a lot of figures around what the attribution of climate change to migration numbers. And I wonder if you could just touch on that a bit more about sort of the robustness or not of those figures as a start, and maybe what is there a definition, or what's your working definition of climate change migration as well? Because, you know, as you said, it's been migration forever, but our present, you know, accelerated climate change and migration.
Yeah, really good questions. My operational definition is the IOM definition. So IOM, the International Organization of Migration, have an climate environmental kind of part of their work. And they've got the most cited definition of climate-related migration, which is people who move within their countries or between countries, either temporarily or permanently, due to climate and environmental change. So it's a nice, neat definition, but as you say, it's difficult to attribute that. And that's where the controversy around numbers really comes. So I did an analysis for my PhD on all of these estimates, and they range from about 200 million to 1 billion people will be on the move due to climate change by 2050. That's like the range. So it's not very helpful. It's a huge range. The consensus lies around the numbers that the IOM tend to refer to, or the most cited numbers, is about 200 million. But I think this conversation has become less popular over time, because when you actually look at the methods, or more controversial over the time, like people talk about it less because there's so much controversy around those numbers. And if you look at the methods, like the Lancet Countdown on Climate Change and Health pulled their climate migration indicator 1 year, because they just looked at the methods and went, well, how did you come to that? A lot of the methodology is around, for example, really about exposure, like how many people are living at sea level and how is that sea level going to rise by 2050, and then assuming that exposure will lead to that migration response. It's quite complicated, because it depends also on mitigation and adaptation. How successful are we going to be at that? It depends on migration policy, like people allowed to move, or are they not allowed to move? And essentially, we're trying to predict human behaviour. And we're also assuming that people always move when there is a climate hazard. So there's a lot of research now about immobility and trapped populations. Climate hazards can just as well reduce migration as increase it. So it's a very complicated formula. But because I've become more...
Sounds huge. You must have had a tough supervisor.
High expectations.
Oh, yeah. Sorry, I digress. That was helpful. Funny.
Feel free to ask questions be selfish and ask questions
about your stuff, yeah.
What I said.
It's a fireside, it's relaxed.
Trish, I'm Sunny. I'm doing a master's here at the university, and also with Rebecca Patrick in sustainable healthcare. Though my question is not related to that. I'm just wondering, going back to the point where you talk about climate migration being a risk exchange, and how people deal with different risks when they move compared to at home, and there's, I guess, a mixed conversation on which one is better. Just thinking that with a very, very cynical perspective of governments, how it could be quite easily and more cost-effective if they wanted to stop climate migration into their country, for them to say, well, rather than trying to make the situation better in the migrants' original place, to disincentivize them moving into their country by making life harder for them here, and then just stopping that from happening. Not that I think it should happen. I'm just wondering if you know of any examples of that happening, how it might happen, and if it does happen, what are the potential impacts or extra complexity in terms of health impacts of that happening on those people?
Do you mean stopping migration, what the impacts are?
Yeah.
Putting barriers up.
Barriers up. Yeah. I mean, like I said, from my experience and the research that I've done, migration is often a last resort. So people would prefer to adapt in situ. and erecting those barriers can worsen health outcomes. Yeah, I was thinking about another answer to that question, but it's just escaped my mind. But I mean, you just have to look at some of the detention and the punitive policies. There probably isn't enough research on the negative health impacts of that, but MSF did do some research as well about detention centres and how like negative that can be on population health as well. So, yeah, sorry, I've thought of another answer, but I've just I'll catch up with you after that about that.
Thank you, Trish. Great overview of all your work and insights on so many different areas. One thing I just wanted to raise is the area of politics in this field of migration, climate and health. We haven't really discussed it yet. And for me, it was really illuminated by spending some time in Kiribati, which is a very small Pacific Island country that you may or may not have heard of. And there's been two distinct approaches to climate-related migration in Kiribati, depending on who the leadership is. So one former leader of the country talked about migration with dignity. So that was an understanding that given changes in the climate, given sea level rise, storm surges and other exposures of the country to these events, that there's likely not to be much of a chance to remain in Kiribati. Switch a couple of years later, and the current leader of the country is has just turned the tables on that idea, and it's absolutely steadfastly, we are remaining in place, and developed countries and multilateral development banks can fund our continued existence, yeah, exactly, in Kiribati. So I just also wanted to raise that because I think that politics is so, I mean, just fundamental to everything we do and the world we live in. And to me, that was a really clear example around the decisions that are being made. And yeah, there's absolutely no talk anymore in Kiribati about potentially thinking about a 10, 20, 30, 40, 50-year plan, given what we know, especially around low-lying atolls, which Kiribati is. So I just wanted to raise that. I also just wanted to say that there are going to be a set of guidelines around detection and attribution that will be released probably early next year. So, and how they're relevant to health. And there'll also be a really great paper. So this is separate to my point on Kiribati, but there'll be a really good paper published by Sarah Perkins Fitzpatrick, hopefully in the next 6 months as well, who is able to plot extreme weather events and show the degree of certainty we have to link them with climate change. So just wanted to throw that in there as well.
For raising those. Anything you'd like to say in relation to not the attribution one? We've got everything out of you on that attribution. The part around politics and the centrality of politics.
That was well said. And that's a really interesting shift. I think Elisa's got another question there too. But I mean, in the Maldives as well, I found a similar thing happening, that the current government have got a centralisation policy where they want to bring everybody in so that they don't have to develop all of these different atolls, and it has its costs and benefits as well. I wonder if there's a change of government, whether that will be rethought.
One question, yeah, and then we'll wrap up. Yeah.
Questions from Chloe from Pangolin Associates. Thanks for joining, Chloe. Chloe's wondering if there's much we can do on an individual level to help those impacted by this intersection, other than, for example, donating directly to different organisations and volunteering. It's come across that the solution is institutional and structural changes across the globe and between sectors. But is there anything you've come across in your research that we as individuals can do, or should we predominantly focus on structural changes and activism?
Question. Yeah, good question. I mean, I think what you can do as an individual really depends on your skill set and, you know, your interests and your capacity, but at least don't make the problem worse is probably it's probably one general piece of advice. And just, I mean, yeah, see how you can leverage what you have to be a part of a solution. Yeah.
And that for you was taking your clinical capabilities, networks, and then taking that into research and being part of the response in generating evidence.
Yeah, I suppose everybody has their moment, but when I came back from South Sudan, I was working in ICU in Germany, just throwing out reams of plastic, just spending an obscene amount of money on, you know, people that had a very poor prognosis. Very elderly people who quite possibly didn't even want what we were doing. And then contrasting that to South Sudan, where people in their 20s were dying of preventable disease because they didn't have access to clean water and basic antibiotics, is what put me into public health full time. So I think everybody might have a moment like that where they think, okay, does this make sense, what I'm doing? And, you know, what's the big problem? What's the big picture? Because I mean, lots of people need meaning in their work, and yeah, different things motivate different people. It's not for everyone as well.
So on that, in terms of well-being is connecting to having meaningful pursuits. How does Trish look after herself in working in this space? I mean, there's some layers. You've shared stories of that. What's something that you would share with our colleagues here in terms of looking after your own well-being as a climate and health researcher?
I mean, I think just keeping positive about it and being humble as well. Like, it's a pretty dire situation, but we can only do what we can do in the time that we've got. And so that's why my strategy is to focus on solution-orientated research and applied research, and research, you know, in a needs-based capacity. MSF's always talking about needs-based. For me, that's about health systems in developing countries, because they're in a terrible place for this. And I think that's quite an urgent priority.
Yeah. Thank you, Trish. I think we can all agree that Trish has been generous with her time and insights, and we appreciate everyone's high level of engagement and joining us today. So thank you again. Keep an eye out